Okay. I guess I'll just start after a minute or two. Do you want me to start?
Yeah, I'm just yeah, we're good to go.
Great. Hi, good afternoon, everyone. My name is Dr. Wai-Yee. I'm a board-certified plastic surgeon. I specialize in breast reconstruction and cosmetic surgery. I'm founder of LA Breast and Body. I'm also adjunct clinical professor at Huntington Hospital in Pasadena. I'm going to go for my presentation. I really want to leave some time for questions at the end. Just my disclosures. So my background is kind of long. I basically grew up in England, London. I did my medical school training there and I graduated in 1996. I then did my residency there. I moved to LA 20 some years ago, did a PhD, did another residency at LA County, a fellowship in craniofacial surgery. And then I was at City of Hope in Duarte for 10 years. And we've been in private practice now for almost 2 years. So just a couple of things. We are recording this. So if you want to come back and look, CSC will have that. And I'm also going to take it for my own practice. So no photos if possible. Just an overview, I'm going to try and touch on several things. And then we can always go back to things if we have time. So I think with breast reconstruction, the important thing for me, my philosophy is it's never one size fits all. So this idea that you can literally sit a patient down in front of a screen and just tell them to read it all themselves and then ask questions, that doesn't really work. I think everyone has very different requirements, just like some people want to go flat and some people want reconstruction. So I'm going to try and cover points for everyone. This is kind of an overview for reconstruction. So, and I also will talk about revision. Is anyone here interested about talking about revision surgery? I see a couple of hands. So let's start at the beginning, and I apologize if any of you already know a lot of this stuff, but we do, in the US, breast reconstruction after lumpectomy or mastectomy is covered by your medical insurance. All patients should have access to see a plastic surgeon even before they decide lumpectomy, mastectomy. Some of my patients, they see me and they said, based on today's visit, I'm going to go back to my breast surgeon and tell them if I want mastectomy or lumpectomy. In terms of timing, just a little bit about the language. Immediate is literally the same day. So you do your lumpectomy or your mastectomy by your breast surgeon, and myself or another plastic surgeon will come and do the reconstruction the same day. That is immediate. Delayed immediate, in my mind, is when we plan to do the mastectomy or the lumpectomy, and I would plan for reconstruction 2 or 3 weeks after. Why would we do that? Well, for instance, if we worry about what we call the margins, if the breast surgeon says, for instance, this is an area that's poorly defined, I'm not 100% sure my lumpectomy will be clean, so let's plan to do the lumpectomy first, and then 2 weeks later, we'll already have the pathology back, and then you can go ahead and do a reduction or a lift or whatever it is that you're planning. Delayed is much longer. So for instance, you have a mastectomy done, maybe you're overwhelmed, which is quite common, and you said, I just can't deal with reconstruction right now. Let me just get my disease under control, be healthy. I'll come back another time. And this can happen years down the road. Lumpectomy is when they take away part of, basically the lump, the cancer, or the area of disease. And they typically have to take what's called an area of margin, meaning it's not got disease, but it's very close to the disease. The other term for lumpectomy is partial mastectomy, and that can be a little bit confusing because a partial mastectomy sounds like half the breast, but sometimes even if they're taking just a 2-centimeter lump, they may call this a partial mastectomy. That means that the rest of the tissue is still there, and typically you will need radiation. But as a plastic surgeon, we can come and rearrange that tissue to give you a nice breast shape and avoid what we call contour deformity. And that takes 2 forms, either a reduction, where someone's always wanted to be a bit smaller in cup size, or a mastopexy, which is a breast lift. And the whole point of a breast lift in that context is just to hide the deformity before radiation. That is very critical because once you're radiated, it is very hard to rearrange things. The tissues are not as pliable, and you can have a lot of problems healing. These are ladies that were sold. Lumpectomy is straightforward. It's easy. It's no-brainer. but they didn't realize they were signing up for deformity. And this lady on the left, I ended up taking a big area of scar tissue that had been radiated, and I had to do a latissimus flap to fix her. This, on the other hand, lady had a right breast cancer. She had a lumpectomy, and I did mastopexy, or breast lift, the same day in that breast, as well as the other breast the same day. She had one surgery, and then she went on and got her radiation. Just a revision for those who are not familiar with the anatomy of the breast. This is a cross-section picture on the right side. So the breast sits on top of the pec major muscle. So when people say, are you putting the implant on top of the muscle? They're talking about this muscle. The pec major sits on the front of the chest. There's a right and a left. When you do a mastectomy, if you look at the picture on the right, you see that black line. That's kind of the outline of where you're going to remove the breast tissue. What you do see, the red and the blues, are the blood vessels. And that is critical, because when you have the breast taken away, for me, when I come in and do the reconstruction, a lot of the blood supply has gone. It's gone with the specimen. So I have to be very mindful of protecting that shell, as it were. So what do I mean by that? Well, for instance, let's say you're an A cup and you said, oh, I'm going to have a mastectomy. I want to be a C cup the same day. That is simply not possible because of that blood supply. I don't know how many of you are familiar with the language of the different types of mastectomy. I'll do a quick review. Modified radical mastectomy. And by the way, I am showing photos, obviously, from clinical patients. This is when the nipple skin and the breast tissue is removed. This is a minority of cases. Everything's gone. This poor lady basically had a surgery done by a general surgeon. In my opinion, this was overly aggressive. The scar actually goes all the way around to the back, and I cannot in the world imagine where you'd need to do that, to be honest. And it is very difficult to live like this. Skin sparing is when the nipple and the breast tissue is removed, but the skin envelope is left intact, and we can use that to do surgery. For instance, if the cancer is very close to the nipple, that nipple will have to be removed as part of your disease eradication. So this patient on the left side, you can see there's actually a cancer right behind that nipple, and that had to be removed. And on the same day, I did implant reconstruction on that side. You can see the nipples and the areola, which is the pigmented part, has been taken off. Now, nipple-sparing mastectomy is when everything is maintained except the breast tissue is scooped out. Patient has breast cancer on the right side. You can see a biopsy site. She wanted both breasts removed. Same day, I did immediate, what we call direct-to-implant reconstruction, both breasts. So breast reconstruction after mastectomy, so you've had your breast removed, you really want a breast replacement, right? So it's either implant-based or autologous. Autologous just simply means we're taking some tissue from you, and I'll go through those. So the benefit of implant-based reconstruction is it's easier in the sense that we're not cutting another part of your body. You're not going to have a donor site. It's easier recovery, it's shorter surgery. And again, as I said, no donor site. However, it is a foreign body. None of us were born with silicone. And often you may need to think about implant change in the future. It is a higher infection risk. I say that, but the infection risk with an implant in my hands is probably 3 to 5%. And I would say that's pretty common. So under or over the muscle, I alluded to this earlier. We're talking about the pec major muscle. Are you putting the implant under or above? So 10 years ago, almost every implant we did would go under the muscle. Now, with better techniques, better imaging, more data on survival, I would say now probably 95% of reconstructions I do now, immediate, I put on top of the muscle, which is better healing, easier recovery. It's not as painful. It's less bloody because you're not dissecting the muscle at all. You're simply putting an implant where your breast tissue was to begin with. And this just shows a diagram. We do use mesh. I use cadaveric mesh that has been processed and is used in breast reconstruction. I'll show you a little photo later. But on the pre-pet, we use the mesh to put, to kind of fix the implant to your tissue. And on the under the muscle, which right now, by the way, I only reserve for people that have very heavy implants because the skin cannot support such a heavy implant. And I did bring some implants to show anyone that's interested. This is alloderm. This is the mesh that I use, which is a biological mesh. This is actually cadaveric skin. It's skin from a deceased individual that has been processed. So there's There's no cells in this whatsoever. And it simply is like a scaffold. It allows your blood vessels to go into it. So the whole thing is covered by vascularized tissue. So this patient I showed you before, and this is really just a contrast between sub-pec, which is implant under the muscle, versus pre-pec, implant on top. This is sub-pec, and you can see the contour. The big difference is the contour. So you have like muscle draping over it, right? Compared to this, which is pre-pec. In this case, patient had a left breast cancer. She wanted both breasts removed, so she had a double nipple sparing mastectomy, and I put both the implants on top of the muscle. And what you do see on the left side is you can kind of see the outline of the implant a little bit more. It doesn't bother most people, and the benefits are as follows. So there's something called animation. Animation simply means when you put the implant under the muscle or sub-pec, when you move that muscle, it twitches, and it bothers some people a lot, and other people just live with it. But when you put it on top of the muscle, you're not going to get that at all. And the difference between these two patients, if you see my patient on the right side, with I've put the implant on top, when she does this, which typically would make that funny movement, you're not going to see it. The other thing we found that if you put the implant on top of the muscle and then they have radiation, there tends to be less capsular contraction, meaning it doesn't go hard as much. So these are contrasting patients. On the this side, what you see is this patient already had cosmetic implants, and then she had breast cancer, was told, do a lumpectomy, no problem, it'll be easy. But she didn't know that her implant would go very hard as a result of the radiation that she received. The patient on the left, on the other hand, is my patient that I put the implant on top of the muscle, and then she was subsequently radiated. You can probably tell on the left side. It's a little bit tighter than the right side, but not this kind of difference. And then breast implants. So I could talk all day. That could be a whole separate talk. Saline versus silicone, different volumes. So up until 2025, the biggest was 800 cc's. Now there's a new implant range called Mental Enhance, which goes up to 1445 cc's. And I brought one here to show anyone that's interested. There's different shapes, but the common shape we use is round. Projection is how much it sticks out, and the width is determined by your own chest width. Expanders. How many of you have heard of expanders? That's 3 out of, okay. So expanders is the commonest way that breast reconstruction is performed in the US. I would say I recently went to a meeting, about 3/4 of the plastic surgeons in the room only did expanders as the first surgery. I hardly ever use expanders, and for a number of reasons. You have to get 2 surgeries. The first one to put the expander in, the second one to swap out the expander. And if you have a complication of the expander, such as it got poked in the wrong place and it's leaking, or it got infected, that's 3 surgeries, because then you have the first expander taken out, a new expander put in, and then the definitive implant exchange. Expansion can be pretty uncomfortable. And most expanders right now on the market are not compatible with MRI. If you should ever need an MRI scan, I did bring one that is compatible. And it can also deform the ribs because of the way the tension goes as it's expanding. This is just a diagram for those not familiar. It is like a water balloon. After the fact, we add fluid and we build it up. And then let's talk about when I would use an expander. This is one of those times. So this patient came to me a couple of years after her mastectomy. Whoever did her mastectomy took away a lot of her tissue. There was simply no way I could put an implant. Oh, okay. Peanut's having a moment. Yeah, I think so. Non-registration. So in this case, we had to do an expander. And when I met with this lady, you know, she's young, she's in her 30s. She wanted the other breast bigger as well. So it wasn't simply matching her native breast, but it was making that side bigger. So we did 2 surgeries. The first one was put an expander. I put some fluid during the surgery. We then did some in-office expansion. The second surgery, we swapped out the expander for an implant, and we did a symmetrizing augmentation on the other side. So that's 2 surgeries. Now I'm going to move to autologous reconstruction, where we're taking tissue from you. I'm going to start with the most simple, as it were, and go most complicated in a stepwise fashion. So aesthetic flat closure, who is familiar with this term? Nobody. Okay. This just means patients they don't want reconstruction. They don't want another breast mount, right? But they also don't want to look deformed. So you have to be very careful, because when you say to your breast surgeon, yeah, I'm overwhelmed, I don't want reconstruction, you have to look them in the eye and say, can you make me look symmetric? Or can I look flat and tidy? Because I don't want any hangy tissue on the sides, right? And if they say, I don't know if I can do that, I can take your breast down, do a mastectomy, then you say, well, can I see a plastic surgeon that maybe has some experience in doing an aesthetic flat closure? Because I see quite a lot of people that are unhappy with their flat closures. And when they talk to me, they'll say, well, I must admit, when I talked to my breast surgeon, I didn't exactly ask details. I just said I didn't want reconstruction. Planned flat closure, meaning at the time of mastectomy, we do the flat closure, gives significantly better results, and especially if you have a plastic surgeon on board. Also, if you're very thin and you're having a mastectomy, it is not as hard to make you look, reasonably good. It's when you're heavier and you have tissue on the side, that's when it's more tricky and challenging. This is a patient who I came back and did what we call revision or delayed flat closure. It means she wasn't happy after her mastectomies, and then because of all this hanging tissue, and then I tidied her up. Obviously, it is harder for me because now the incision is already set and there's only so much I can do. On the other hand, if someone has been diagnosed, they decided they want double mastectomy, but they want to be aesthetic flat closure, and they see a plastic surgeon and we plan together, like for instance, I would be available on the day, then we have a much better result, if that makes sense. Who has heard of Goldilocks procedure? Okay, congratulations, because if I was in a room asking this even 8 years ago, no one's really heard of it, and even some doctors haven't heard of it. Right. So Goldilocks is basically a patient is typically undergoing a skin sparing mastectomy. That means it's safe to leave the skin behind, but the nipple's been taken away. But we use that leftover tissue and fold it in a clever way, much like a breast reduction, to make you a small breast mound. So it's all your tissue, there's no implants, and you're not completely flat. And a lot of patients, their biggest fear is being concave, being caved in after mastectomy. It is a much easier recovery and it's an easier surgery. But the downside is you have to have big breasts in order to have that much tissue to rearrange. If you're an A cup, you cannot get a Goldilocks because there's just nothing to rearrange. And this is a patient that, really, which is one of my best cases in like 12 years because she had very big breasts. Tissue flaps. So I'm sure you've all heard of different types of flaps. What is a flap? So a flap is just a piece of tissue from you, typically muscle, not always, skin and what we call fascia with a blood supply. So the latissimus flap comes from the back. It's what's called a pedicord flap. A pedicord flap means the blood vessel, the original blood vessel, is still connected. You're not cutting the blood vessel and reconnecting it. So that reduces the risks of the blood supply having problems. I specialize in latissimus. I really like doing this case. I've done many of them. I've published a couple of papers on it. It is what we call historic flap, meaning if you go back in history of how we did reconstruction, this was one of the first forms of breast reconstruction using your tissue. As again, it's a pedicle flap. The what we call the rate of flap loss, meaning you can lose the whole tissue, is extremely low, like 0. Well, I wouldn't say 0, but close to 0. In my hands, it's a one-night stay. This is just a diagram. So basically, you take the tissue from here, you dissect out the blood vessels, you free up the little tunnel, and then you bring it to the front. It became unpopular mainly because of this back scar. People didn't like that, what we call an oblique. I know, right? Exactly. You can't blame them, right? So the other, right? Well, the thing, and then it's also that everyone said, oh, you have to get an expander, an implant. So I did my own series over 100 cases, and 3/4 of the patients I did end up putting an implant, but a quarter did not. That's like 30 plus patients. Seroma rates, that means fluids in the back. My stroma rate is very, very low, less than 5%, because I'm very, let's say, generous with my drains. I do believe in drains. And if you keep the drains in for an amount of time, you can avoid seroma most of the time. And then before, people would stay 2 or 3 nights. Now, as I say, my patients go home next morning. And mainly because I use intercostal blocks where I block the nerves using a long-acting local anesthetic called Exparel, and that lasts about 5 days. So I call this a combined bra line backlift latissimus flap. And basically, I modified the flap design so that the scar is transverse or horizontal, and you can hide it in the bra line. And this borrows from one of the cosmetic like body contouring techniques that we did called the bra line backlift, where, you know, when you have those stubborn rolls, and basically you get cosmetic surgery to cut that out, and you hide the scars within the bra line. So I was like, well, why don't we just do both? You know, we'll take those rolls and we put them to good use and make you a breast. This is one of my patients. On the left side, she's radiated. So when you're radiated, we typically like to put flaps, unless it's the same day, like I talked about the implant, we put, you know, pre-pec. But if you're doing a delayed reconstruction, meaning they never got reconstruction at the time of mastectomy, they are subsequently radiated, it is far safer and standard of care to use your tissue, autologous reconstruction, because of healing problems. You can see on the right side, I went direct to implant because she hadn't been radiated. And on the left side, that skin paddle is from her back. So that is back skin. And you can see when she's wearing a bra or even a bikini, you really can't see the scars that she has. And this is the back scar, which I think is much better than the oblique scar that we saw earlier. And this is what we call symmetrizing bra line backlift, meaning a patient came to me, I did a latissimus the way I do it, and she liked it so much, she wanted the roll on the other side taken off to match it, and that's what we did. You can see we took this away. And when she was wearing a bra, again, it's concealed. And as I said, not everybody needs an implant with a latissimus flap. So this lady had actually really gone through the ringer. She'd had both breasts taken away because she had locally advanced disease. So she had to get radiation and nobody would do her reconstruction. She's also heavier. Her BMI is 38, which makes healing a little bit more risky. And she also had some rolls that I could use. So I did, you know, bilateral latissimus flap. This is all her. There's no implant in there. And we've helped the contour of her back as well. And you don't have to be BMI 38 to avoid an implant. So you can see here, this lady is not as heavy as the last lady. She didn't have like huge rolls or anything, but I was able to use the tissue and basically do a breast reconstruction. Yeah, where's this one? Okay, so you saw how the other lady was heavier and she had rolls, right? But this lady doesn't. She's not very heavy, but I was still able to use, so she actually got it all done in one day. So she had double mastectomy, same day. I used the tissue from her back, the latissimus flaps. I did 2 latissimus flaps. This is the tissue. And then that's all her. That's all autologous. There's no implant. Does that make sense? You look puzzled.
No, it's just brilliant.
Oh, thank you. I'll take that. Yeah. So this, let me show you. I've already harvested or collected the breast tissue, the flaps. I've pushed them through the tunnel. We've now flipped the patient onto her front, yes. So this is her sternum, as it were, her chest bone. And this is the space, and then I'm now going to inset it to make her a breast.
That's the ending.
That is the ending, yes. Oh, I hid it. So I took this skin off and I buried it because we were able to do nipple sparing mastectomy on her. Does that make sense? It's like magic, I know. So this tissue is underneath her now. But in order to bury skin so that it doesn't have problems, you have to take this top layer of skin off, but the rest of the tissue is still healthy because it has a blood supply, and we pop it inside. And then all of this is hidden. So you see her scar is here, and the same on that side. I can't reach. But is her own breast. Correct. Yeah, it's hidden. Correct. So we take the top layer of the skin off, it's called de-epithelialization. So the epithelium is the top layer. You can't bury it, otherwise it's gonna have problems. So you just take that bit off and then you pop it inside. Yeah, it's quite straightforward, actually. And then this is just showing you a latissimus. This lady came to me, she had been radiated. You can see they already went to town, they took everything away. She wanted to be bigger than this, and she wanted the breast, okay? So with this case, I did the latissimus, I put an implant same time, I did an augmentation. She came back for a nipple reconstruction, and I'll talk about that in a second. And then we did tattooing on that side. Make sense? Great. So deep, I'm sure everyone's heard of a deep flap, right? So a lot of these terminology is a bit confusing because half of them are anatomy, and a deep flap is not because it's deep, like under the tissues, but because of the blood vessel. So blood vessel is the deep inferior epigastric perforator, and that's what the flap is based off. And this is like an updated version of the tram flap, which you may have heard of. Now the tram flap, these are both belly flaps, right? But the tram flap was more morbid because we would take the rectus muscle, which is the main muscle that helps you sit up, which was a big deal. So the perforator flap, we still have to dig through that muscle to get the blood vessels out, but it is less morbid because we're not taking the muscle away. However, even with a deep flap, there is still a bulge rate. What a bulge is when it's like a permanent bulge, right? That you can't get rid of. So I will say a lot of people say, oh, you're getting a free tummy tuck, you should be so grateful. And I don't subscribe to that because you are interfering with someone's core tissues, right? I like Pilates. I don't know if you like Pilates or yoga. It's a big deal. And I've actually, since going to chiropractic, I don't do this flap anymore. But I do know patients that have had very good results from it. So I would say this flap is great if you have a nice tummy and you want to go flatter. You have a lot of time for recovery and preferably have a lot of people to take care of you during that time. And you don't want implants. You've got a big amount of tissue here that you want to put to good use. That's who a deep flap is really good for. If you're skinnier, and your plastic surgeon says, well, we need to fatten you up, you're going to have pizzas for a year. I don't agree with that at all because those patients, they're always invariably way too tight where it is uncomfortable and it is very hard to recover from that. So this is a deep flap. It is a free flap. Remember how I said the other one is a pedicled flap, like it's swung over like a yo-yo, keeping its original blood supply. This is not. This one, we carefully dissect out the vessels, we clip them, and then we dig out your chest wall vessels up here, and we reconnect it using a microscope. The problem with that is often this area has been radiated, and those vessels are not always very healthy. So even though you do a beautiful joint called an anastomosis, you can have a blood clot form there, and it could block off the flap. And that's where you get into flap loss. Flap loss means it changes color. We take you back in the middle of the night typically, and we try and salvage this flap. And it is a devastating thing to happen to someone. And it is off, sometimes we can save it, sometimes we cannot save it. That's why if you're going for any of these complex surgeries, make sure you choose your surgeon very carefully. Like anything else, you want someone that's had a lot of experience, they've done a lot of reps. You want to ask about before and after photos. That's really important. And if you ladies want, I do have a couple of slides about choosing a plastic surgeon, only if you're interested. So this is a deep flap. So as I say, free deep is great if you don't want to use an implant at all and you have a lot of tummy to give, okay? This is one of my patients, but you see that it's a hip-to-hip incision. Is this a tummy tuck? Not really. Does she look more svelte? Of course, but it's not a tummy tuck. The difference is we are actually violating what we call the fascia, which is that tough tissue that is a strength layer, whereas in a tummy tuck, you're just going to tighten it, right? So that's quite different. But, she doesn't have this now, which, she was very happy, I can tell you. But, you have to know what you're signing up for. So this, you're getting a free tummy tuck, you should be so grateful. I do not subscribe to that. And that's basically a couple of surgeries. We put the flap, I shaped the flap, I did a nipple recon, and then we did a tattoo on her. But she had a lot of help. You know, she had daughters. Go ahead.
Tattoos on it?
This one is a reconstructed nipple, and it's been tattooed subsequent to that. This is her original nipple.
So, okay, so you just take the stem and make it look like it.
I'll show you.
Then you cut.
Hold that thought. I'll show you shortly. Okay. So nipple reinnervation. Has anyone heard of this? Okay. So when you get nipple sparing, if you are a candidate for nipple sparing mastectomy, the issue is, remember how I said you kind of take out that tissue? Well, the nerves are all cut. So typically, even if you can keep your nipple, it doesn't have normal sensation or sometimes zero sensation. And that tends to be permanent. So there are some newer techniques. I mean, I probably getting a bit more popular about 4 or 5 years ago, where we asked the breast surgeons to preserve a little stump of the original nerve, and we reconnect it to your nipple using what we called cadaveric nerve graft. And we use these for trauma for many, many years. So someone, you know, cuts their wrist and they have a defect. We get it off of a packet. It's a nerve graft that's been treated, and we stitch it together. So this is one of my cases where you see that's the nerve stump that's been preserved, you know, that belongs to the patient. And these are under a microscope image. And then this is a microscope image. This is the cadaveric nerve graft. We put a little collar around it, but we stitch it together. And then this is like the underside of the nipple. So it's been flipped inside out. And then we plumb it down. This is alloderm because she was getting implant-based reconstruction as well. And this is the patient with her implants. We did the double mastectomy, immediate implant, and then cadaveric nerve graft as well. And then we're just going to talk a little bit about nipple reconstruction and tattoos. So the benefit of having the surgery is you have something that sticks out, right? But you do have to have another surgery, but it is probably one of the easier surgeries. You don't have to have drains, you don't have to be in hospital, recovery is pretty easy, you just put a dressing on it. And then we'll talk a little bit about tattoos. So this was the patient, so this will show you visually how we do it. So I match it, so I measure this, I match it there, I raise the flaps, okay? And then you see this little bit, the way I describe it typically is, imagine this is a lady with her arms outstretched, and that's her skirt. And if she hugs herself, you make the column of the nipple, that's that. And then you bring these bits together, and then you purse string around the whole thing. Make sense? Got it. And then tattoo later. It has to heal before you can tattoo. Does that answer your question? Okay, but don't try it. So that's before and after, which we saw earlier. And then, this is Tracy Young, by the way, my nurse practitioner. So we worked together at City of Hope for 10 plus years. She's been doing nipple tattooing for more than 10 years. And she also does 3D nipple tattoos. This is her work. And she can also answer questions at the end if anyone has any questions. But this avoids surgery, right? So it's tattoo. We do this in the office. You don't need to get surgery. And then just some things about resources. I think I'm on time. I'm trying to leave a little time to questions. This is my practice. We're all female solo practice in Arcadia and Pasadena. We are moving to South Pasadena later this year. And we provide very personalized care. We've both been in cancer care for a long time at this point. I do ultrasound as well for my implant monitoring, which is complimentary. I also have a YouTube educational channel if anyone is interested. We cover a lot of things, including expanders, implants, flat closure. It's not like glamorous or anything. It is literally how do you take care of a surgical drain, right? What are your options? And then I have a resource on my website, which is a learning center for people that want to learn about breast reconstruction and implants. And these are some of my contact information. So I don't know do you guys want me to go through about choosing a plastic surgeon? I don't know if anyone has any interest. Nobody? Okay. The important thing is make sure that they're board certified. Okay, and they have experience, and you really want to see before and after photos before, you know, if possible. Okay, I'm happy to take questions.
You take like the Medicare, HMO.
We are not in network for any insurance, but we can use BPO insurance. Yeah, yeah. Go ahead.
Is the person who type breast cancer like breast?
Yes. Yes. Yes.
And they want to have a Goldilocks procedure because the radiation can only keep on days, but so that if anything happens to the other breast, I mean, it's less likely. And the person had open heart surgery like 2 years ago, so the family vessels have already been applied for the heart because of Goldilocks, full sparing, but so flexible. Insurance usually take that if it's like an deal.
Yeah. So I'm just going to repeat your question because I don't think.
Really
No, I think I've got most of it, but correct me if I'm wrong. So because people can't hear on Zoom. So the question is, if someone has a tiny breast cancer on the left side, wants to get double mastectomy and has no family history or genetics mutation that increase their risk of getting breast cancer, yeah, can they get a Goldilocks? And there's a 2 years ago underwent cardiac surgery, correct? Goldilocks, totally fine. So let me take one at a time. Yes, you can definitely have a Goldilocks. Had the internal mammary vessels, it would be hard to do a free flap because your vessel is gone, but there are alternatives.
Yes, sweetie.
I don't know who that is. That was weird. So yes, you could definitely get a Goldilocks. In fact, that will probably be the better surgery for someone who's had a cardiac history because it's a quicker surgery than, say, do a free flap, right? In terms of getting a risk-reducing mastectomy for peace of mind, you know, without the BRCA1 or whatever, that is completely up to you and your breast surgeon. Some breast surgeons are totally fine with it, and other breast surgeons will simply refuse to do a prophylactic on the other side. That is between you and them. I mean, from my standpoint, it obviously makes it nicer for reconstruction, but that should never be a decision-making point. But I totally get it. I have to say, in more than 10 years of practice, I can't remember who had regretted having the other side removed for prophylaxis or risk reducing. Does that answer all your regrets? Regretting, saying, oh, I didn't have cancer on the other side and I had my breast taken off, I regret it. They don't regret it.
Because once the radiation is done, it can affect the breast later on.
So radiation will affect the breast that has been radiated. They're not going to radiate the non-affected side. Does that make sense? Yeah.
It's also on the left side when coronary or part work is done on the left.
Yes, right. But I'm just saying, because what you're saying is, should I just get it done because then I'll be radiated? It's not going to affect the right breast that you were radiated on the left breast. Right.
So I'm just saying so that I don't
have to come back and you don't have to worry about mammograms. Yes, totally understand that. Yes, it's very common. So we had a lot of patients that wanted bilateral mastectomy and having one side disease. Very common. Yeah. Is there a question? Oh, how am I gonna? Oh, did she regret it? Oh, I'm sorry. Oh. Okay. I don't know if I can see it. I'm gonna look on this one. Okay, let's see. Okay, Victoria has a question. I had double mastectomy 2024, but now I regret not having reconstruction. Can I still do reconstruction? I had radiation as well. Okay, yes and yes. So yes, Victoria, you can get reconstruction, is what we call delayed reconstruction. Like I showed you on my slide, the side that got radiated, you should get some kind of autologous reconstruction, some kind of flap, latissimus, deep flap, pap flap, whatever. The other side, if you have tissue left over, you can get an implant. If not, you might need a tissue expander and then an implant. So absolutely. I don't know if I can see the other. Tracy, can I get you to come and see if you can fish out all the other chats? Because I see 4 new chats and I've only just answered one of them. Because it should just be. Yes, go ahead.
I had this one taken off and radiated.
Yes.
This one 2 years later, I had it taken off, that was really large.
Yes.
And I was,
Yes, lopsided.
So, around 2019, they
Yeah.
put expanders in,
Yes.
and then the pandemic came in,
Okay.
all that. So this one's capsulated, and this one popped, and there's still the
So you still have expanders in right now from 2019? Okay. So I took out.
then I mean, I just go to the doctor and you just go to, your HMO and you get this doctor. So I can't do that. I have extreme fear. So I don't know how to get a doctor that I can trust.
Well, number one, look up if they're board certified. So if you have an HMO, your HMO is going to tell you who is in network, right? So then you do. Well, that's the problem, you don't, So, but some of it, you'll get a sense when you meet them if they know what they're talking about. And if they don't have photos, to me, it's a bit of a red flag, But you can also make sure they're board certified. That's like a no-brainer, right? Are you board certified? You can look it up. And if you're interested, I have that slide, which is here. That's free. You can literally plug in their name and it will tell you when they were board certified. You could take a picture if you want. It's on my website and stuff. Oh, okay. We'll teach you. So, and I have brochures. But literally, so they're cycle board eligible. Board eligible means they've graduated, they've done their residency, but they haven't quite done enough cases and been out of training long enough to do. Normally, it's about 1.5 to 2 years, which is the earliest time you can become board certified. But again, it's whether or not you want to be in that learning phase of someone who's just come out, But board certification is a basic, I would say. And then experience and photos, word of mouth. So some, I would say physical therapy, nursing, a lot of them know who's good and who's not. Some patient reviews. I would say one thing about patient reviews. So when you work in a hospital, I don't know if you know this, but the hospital can scrub the reviews, right? So they'll filter the good ones and keep them, and the bad ones get removed often. I'm not talking any particular place, but that is just the way corporations work, right? Oh, absolutely. Yes. But third party, like health grades and stuff, they cannot, no one can touch those, right? Does that make sense? Because if you go to an institution, that institution, they care about their review a lot, and there's a whole marketing team, and their whole job is to clean those kind of, they can't make things up, because they can certainly remove the bad reviews. So yeah. Another question. Melissa, are there any surgeons you particularly recommend for nerve grafting in the LA area? I do it, okay. Dr. Jim Anderson at Huntington does it. And these are not just people who do it, but these are, looking good surgeons. So and he does take insurance. He works at Cedars. Okay. Hi, Dr. Lee. Sorry if I missed it, but what if I don't have enough tissue for a flap and need to have radiation? Well, if you haven't yet had a mastectomy, is this the previous?
No.
Okay. If you haven't had radiation, you can just put an implant and then you get radiated. Make sure it's pre-pec, meaning in front of the muscle. If you don't have enough tissue for a flap, it depends. I'm going to tell you right now. It depends if you've had mastectomy or not. That's the biggest thing. Because if you have no,
I did have a mastectomy. I have expanders in. I start radiation tomorrow. And my doctor, I love my plastic surgeon, but she typically does not do implants with radiated skin, but I'm just so petite, and she's trying to push me to do even potentially a hybrid, but I just don't have a lot of extra tissue on my body
What do you mean by
one
hybrid?
side.
You're talking about like a latissimus flap?
I think she said, I think so, yeah, from my lats, she said is the
Mhm.
best place for petite people.
I have yet to find a patient I cannot do a latissimus flap on. And I've
Okay.
dealt with a lot of Asian patients that have a low body mass index and they
Okay.
don't have rolls or anything like that. I should have showed the photo of this lady's back. She had nothing, but I was
Okay.
able to get that amount of tissue to add to the volume because she didn't want implants. So
Okay.
I really haven't, and you don't look big, but you don't look like emaciated. You know what I mean? Yeah, I'm
No.
sure you have some tissue there. Yeah.
Okay, that's
Now, answer your
reassuring.
question.
Yes, thank you.
You're welcome. Grace, Dr. Lee, I am interested in a revision consult of you. May I ask which facilities you operate out of? Yes. So I operate out of Huntington Hospital, USC Arcadia Methodist, which is in Arcadia, and then Glendale Adventist in Glendale. That's it. Any other questions?
How much do you charge for consultation?
It depends. Cosmetics is one charge, but for reconstruction, we often don't charge, do we, Tracy? Yeah. Reconstruction consultation. Mm-hmm. Yeah. The only time we do charge is, let's say someone belongs to, say, Kaiser. I'm never going to do surgery on them. And they say, listen, I already have a surgeon picked out at Kaiser. I'm going to go Kaiser, but I really want your opinion. Can you sit and go through my records, that's like a consultant, right? And I will spend time going through everything. I will do the consult, I measure them, I take photos for them, and then we give them a PDF of my recommendations, like a blueprint, and then we charge for that. Yeah. Does that make sense?
So
Yeah.
What you would do,
Mm.
or this is what I'd like if possible.
Yes, so all of that.
You may not have.
I do work with insurance. So if you have PPO, we work with PPO insurance. Yes, we do. If you have out, yes, that I don't. Yeah. Yes. So the consultation, basically we do a history and physical, just like you do any other consultation. I do examine the breast and I take very standard measurements that everyone should do, if you ask me. And then I will show you photos. I will go through your options and I'll go through what I recommend for you because everyone's different. You know, if you want something that's impossible, I'll tell you it's not possible. Don't do that. Does that make sense? Yeah.
I felt something like that, and then I have to go to the home.
Yeah.
And I go to whoever they decide,
Right. Yes.
and then I have that.
Right.
Two things.
Yeah.
Work among them.
For sure. Yeah, like for instance, as I said, we have people from Kaiser. You know, they're not going to leave well, there have been some people that change insurance so that we can use PPO and work on them. And so basically those patients, if we know that we're never going to do their surgery, then we do charge, which is actually a very reasonable fee for what is essentially like 2 hours. We see patients for an hour to an hour and a half. We give them, I go through their records to see what's happened, because some people are quite complicated, and then we give them, as I say, a PDF of what we recommend. It's quite a long document. It's 5 to 6 pages of what we recommend and giving them a lot of background. Yeah. Yes.
But I would love to consult with you because
Yeah.
I love to jump ship.
Yeah. Yeah.
Are you saying you would be willing to?
Yes. We'd be waiting to see you. I mean, yeah. Any other questions? Although you've heard a lot of it and you're really an expert. Are you saying you didn't learn anything today?
No, I did. I just don't know what's
Yeah.
work.
Right. So a lot of it is nuance. It depends on how you are and I take into consideration the social aspect. So do you have anyone at home helping you? Because that's a big deal. When I have there was a lady we were going to do a free flap. Remember, Tracy? And one day she was like 2 hours late for the visit. And I was like, why is she so late? She has to get like 3 buses from Long Beach. And I was like, she's not going to be a candidate for a big surgery because she has no one to take care of her. And so we delayed it until she have people to take care of her. Question.
side's encapsulated.
Sorry?
So this side is.
Yes,
encapsulated.
yes.
What's that consist?
And you're not radiated, is that right on that side? You are radiated. So that would mean you'd need some kind of a flap. You need some tissue there. Yes. Because if you take out the so okay, so back up a little bit. When an implant is encapsulated, what we call capsular contraction, your breast, when you put an implant in, your breast forms a scar around it called a capsule, which is normally thin and pliable. However, it can go very, very hard, like a rock, right? And it's very uncomfortable. So it can be painful. So we typically strip that capsule away, but we have to put something like some tissue, like your tissue, to stop it coming back. Otherwise, it will just reform. That's a great question. So if your mastectomy flap, your original mastectomy flap was very, very thin and the capsule was right stuck to it, then you might have to remove some of that skin, which is why if you're taking a flap, like from the back or from the tummy, you're going to take that skin paddle with it, and then you're going to see that skin paddle there. Does that make sense? Because you're replacing the skin as well. Yeah, that's a very good technical question. It's probably very stuck. Yeah. Yeah, I believe it. Yeah, yeah. But your muscle should still be there. So the major is still there, unless the tumor was involving the muscle, which can happen. Yeah. But the muscle's only triangular. The lower part isn't there, right? Because of the shape. Question.
Yes, that's why I can't get it done. I can't, I have to have somebody tell me, how this is going to happen. I just have Joe Blow off of
No,
paper.
I completely understand. It is worrying. That's the thing. Yeah. Well, try, some of the breast groups, people talk, they give tips to each other. Yeah. Question. Hi, Peter. Oh, that's a great question. So I'm actually writing a paper right now. So the question is there a lifespan of implants? So for the longest of time, we were told implants had to be changed every 10, 15 years. And in fact, some patients would be like, I can't be bothered because I don't want to come back in 10 years and have the implant changed. However, so the old implants were not built to the same standard, right? The newer implants, and you can see if you can try and break that apart. Don't stab it though, but they're very, very tough. And the rupture rate is very low these days. So actually, as I said, I'm writing a paper right now with my medical student. The evidence is showing that really, unless it's broken, you don't necessarily need to change it, but you do need to do implant surveillance. What do I mean? I mean, you have to have imaging after typically 5-6 years, ultrasound or MRI, make sure it's not leaking, and then every 2 or 3 years, just to maintain. But you don't necessarily have to rush out at year 10 and say, oh, I want it changed. I need it changed. Does that make sense? Because it makes it less of a big deal, right? Because if someone says, oh, here's your implant, it's only going to be 10 years, then people are like, oh, I don't want to do this. Yeah. Is there another question? There's a follow-up question from Melissa. Can you explain what percentage of sensation sparing nerve grafts are successful? Okay, that's a great question, Melissa. I have not revisited the data recently, so I don't want to just throw up a number. Anecdotally, for me, I would say maybe about 60%, but it's never 100%. So I hope that answers that. But I would probably have to look up the numbers to know exactly. I have to say though, like about 4 years ago when 4 or 5 years ago when it was more popular. Now I hardly get anyone asked for it. Yeah, yeah, it's just one of those things. So it's just like, I don't know if you heard of robotic mastectomies. So this idea of using, minimally invasive to do a mastectomy, it was quite popular, I don't know, about 3-4 years ago. And I'll be honest, if you still need to put an implant and make a big old incision, there's no point spending 8 hours doing a mastectomy using robot just to make a big incision to put the implant in. It doesn't make any sense because the longer you're under anesthesia, the more risk of certain complications, including infection. So, okay. Any other questions? No. I hope that was helpful. I got some brochures. If you have any follow, and then, oh, another question. Okay, one more question about implants and radiation. Why do some surgeons do it and others avoid it? I think is this Melissa still? Melissa or MB? I think it's down to experience. Years and years ago, some radiation doctors wanted it to be an expander so you could deflate it to get the radiation. But I have a lot of friends who are radiation oncologists. We've never had a request to deflate the expander in order to get radiation. So I quite frankly don't even know why these people insist on putting in an expander when you know that tissue isn't healthy, right? Once it's radiated, and then you're committing that patient to getting a second surgery in radiated tissue. And I mean, some people do already plan to put a flap in there. They're like, you're going to get radiation. We're going to do a tummy flap. So let's put an expander and make your skin bigger, right? To make the envelope bigger. So I can understand them wanting to do that. But it is quite uncomfortable for patients when you expand it. It's quite full feeling, right? And then they have to go for radiation as well.
Okay. Maybe that's why they didn't fill my expander all the way too.
Yeah. So the other thing you said was, I know several women that had an expander during radiation and haven't had issues with implants. Yes, you can get away with it. I can also show you people that did not get away with it, that have had repeated infections, the wound unraveling, what we call wound dehiscence, and we ultimately have to do a flap. Yes, you can take your risk and do it, and it might be fine, okay? But if you look at the standard of care is autologous reconstruction once you're radiated.
Okay.
But I certainly have had pre-PEC patients that are radiated and they've done fine.
Okay.
Because the other thing is that when you put implants under the muscle, which is what we used to do for every single patient, and then you radiate them, the muscle itself undergoes what we call fibrosis, where the muscle goes hard as well. So now by moving the implant on top of the muscle, you're no longer putting the muscle like closer to the radiation beams, if that makes sense.
Mm-hmm. So muscle is actually affected by radiation?
Yes, it's called muscle fibrosis.
Okay.
Yeah.
Thank you.
You're welcome. Any other questions? Good. Oh, no worries.
Carry the skin. So you're not actually just taking the skin. You're not taking the skin and just putting it here with the skin.
You can. So it depends. It depends. So you have to get the blood. It's not a skin graft, if that's what you're thinking. A skin. So yeah. So a skin graft is when you're just taking the skin, there's no blood supply, and then you put it onto the wound, like a burn patient, right? But here you don't just do skin, just to be clear, because you need the volume, right? So for instance, if it's on the back, it's called myocutaneous. I mean, myo is muscle, cutaneous is skin. And in between you have fascia. So you're taking the whole bulk of tissue, and it has to have a blood supply to keep it alive, right? When you're taking from the tummy, again, with the deep flap, you're not really taking muscle, or at least if you do it properly, you don't really take muscle, but you're not there to see. But basically, you're taking skin and fascia, and then you're taking out the blood vessels. You have to dissect out a long piece of blood vessel called the pedicle, because you have to then plumb it into your vessels here, what we call the recipient vessels. Absolutely. It's already connected. We dissect it free so it can swing around like a yo-yo or a pendulum. Yeah. Uh-huh. Yes.
I picture you stay as it is.
Yes. It definitely, so that's a great question about disruption of the fascia. So fascia, I don't know if any of you eat meat, but if you look at steak, that white glistening tissue, it's quite tough, right? It's on above the muscle. That's your strength layer. You still have to go through that in order to get the blood vessels out. The anatomy of your blood vessels does determine how much you have to disrupt it. That's why, a lot of them, we would do like a CT angiogram to look at the blood vessels. But either way, you normally have to dissect through that and disrupt it. That's why there is still what's called a permanent bulge rate, like a bulge, even with a deep flap. You patch it together, you sew it together, often you repair it, but it's not, yeah, just like if you, right, like if you crack a cup, it's always got a crack in it, right? I mean, yeah. Mm-hmm. It's very important. Yes. Yes. Yeah. No, it is true. That's why it is very difficult to recover from. Yeah. Mm-hmm.
So I've seen two different doctors and none of them mentioned taking this or anything like
You mean from the back? Yeah, I mean, yeah. Well, everything depends on risk, right? So for instance, if a patient's a smoker, people may not necessarily talk to them about, tissue transfer, right? Because if you're a smoker, your blood vessels do not behave normally, you're not even a candidate. Does that make sense? Also heavy. If you're high body mass index, a lot of people, well, it's way too risky to do any kind of flap usually. Okay? So a lot of it is to do with risk factors, which is why the history is important.
If they do that,
Mhm.
and then you lose some weight,
Mhm.
do they deflate?
Does what deflate? The tissue?
Yeah.
So I haven't seen a lot of tissue deflation from a flap. In theory, yes. And also, if it came from the tummy, for instance, and you tend to lose weight on your tummy when you lose weight, then yes, in theory, the layer of fat tissue could go down. That is true. But it wouldn't deflate to like nothing, Yeah. But, I do, over the year, I've had patients that I say, right now you're too heavy for us to do this and this. If you lost this amount of weight, then we can talk. That makes sense?
Yeah.
But I wouldn't like not talk about it. I'd still say, hey, here are the options. However, right now you're not the best candidate for this and this. We could consider this, just
even, I get zero anything about a flap or anything like that.
Yeah.
Nobody talks about it at all.
right. Just like if you're diabetic, if you're very poor. So when I have patients that are diabetic, I look at the A1C. If it's like 15, I'm like, hey, you're not getting reconstruction because the risks are simply not worth it. Yeah. Question.
You never mentioned that, right?
So, okay, fat grafting. We're talking about fat grafting. So fat grafting is, I'll come back to that's a good question, Sherry. So fat grafting is when you lipose up fat and then you put it in like it's a filler. So I personally I've done fat grafting quite a bit, but I don't like it. And here's why. So when you fat graft, there is no blood supply, right? So you're sucking this fat, you run it through like a filter and then you inject it back in, which sounds really nice, but it has to find a blood supply. So typically fat grafting is what we call serial fat grafting, meaning one is never enough. You have to do multiple rounds of fat grafting under anesthesia. And then let's say we took 100 cc's of stuff, at most 50 cc's will survive 3 months. So the other 50 cc gets absorbed by your body, but some of it undergoes what we call fat necrosis. Fat necrosis is scar tissue of that fat that hasn't healed. And it can present as a lump. Which breast cancer patient wants to have a lump, 6 months down the line? And then they get you a mammo or some kind of imaging, it can become calcified. And again, it is very deceptive. And we've had patients over the years that have fat grafting and they can feel this lump and everyone says, oh, we did an ultrasound, we think it's fat necrosis. Who wants to live with that kind of assumption, right? I just don't think it's worth it, to be honest. You cannot really get a whole breast using fat grafting alone. At least I can't. It's, and you might see people that claim to make a big C cup using fat grafting alone. I would be very hesitant to believe those results. Does that make sense?
Thank you.
Yeah, you're welcome. So the question is it preferred to have a deep flap before radiation or after? So the way I see it is if you're going to go to the trouble of having any kind of flap, you might as well wait till after you've healed from radiation. I usually wait a year. You could probably do it a little bit earlier than that, because when you put a flap on, you kind of don't need that flap to get radiated. The whole point is you want to radiate the bed where the cancer was, right? why would you bring nice healthy tissue from the back or the tummy and radiate it? Because it could go hard as well. And then it's a waste of that tissue because you can't go back for seconds, right? It's already been taken. So it doesn't, in my mind, I would always tell patients, if we're going to go for a flap, let's just hold off and we'll wait till you've recovered from radiation. And then we have nice, clean tissue that hasn't been radiated, Cherry. Any other questions? And I brought some implants and expanders if anyone wants to see. Yeah. That's, you mean in the context of cancer or just in general? Or just downsizing? Yeah. So any downsizing, it's actually, yeah. So that's a great question. How do we downsize when we have implants after mastectomy? If you look on my website, I have a really good example of that. This lady was like, when I had my mastectomy, I asked for a B for boy, I ended up for D for dog. And I've always hated, this is grotesque. I'm so embarrassed. We downsized her. So it's not just changing the implant. You have to downsize the envelope, so it fits nicely and it looks reasonably well, good. So yeah, it's totally possible. Yeah, the width is pretty fixed, but we can definitely go down on what we call the projection or the profile, and also the heaviness of the implant. Yeah. Okay. That side boob, yes, you do take out side boob. People love having their side boob removed because no one wants it hanging over here, right? No, that's like what, an hour, like that. Yeah. So we just wedge it out and we line it up, and it's nice and smooth. Yeah. I know. So that's why it's very important when women say, I don't want reconstruction, I just want a mastectomy. They have to be very careful what they're asking for, because when it looks like all the hangy stuff, technically they've had their mastectomies. They did exactly what was expected of them. Do you know what I'm saying? Because this isn't breast over here. But when you have a big breast and it's all together, you don't notice it. But when they say this is the breast, this stuff isn't, we're just gonna leave it. Yeah, she was pretty sad. Yeah. But technically her breast surgeon did nothing wrong.
No.
She did a double mastectomy. So it's so you have to be very careful what you ask for.
Isn't this still part of somebody's breast?
No, that is not part of someone's breast. This is a lateral chest wall.
It's just fat.
Yes, and skin. The skin there as well. Yes. Yeah.
But it's never considered.
And it's not. So I would say, if people really care, and who doesn't care? Do you know what I mean? Like it's part of your care. Does that make sense? You have access. Here we're living in LA. There's loads of plastic surgeons in general, and so you have access. People living in rural areas, it's harder because they don't have access. So. But that's not their territory. And the breast tissue. No, they're not trained to make things pretty. I've seen women like that with big old staples. Remember, Tracy? Like 50 staples across. It's terrible. But you don't, they're also the type of, they're not going to show you photos, are they, of staples? They're not going to show you photos of their work, So I would be very careful. So in general, I would say, if possible, I want to see your photos. I want to see your results. And if they don't have photos, why? Do you just not have good photos? Do you not take photos? Do you not do much surgery? What is the reason? Right. Except, guess what? You may be overwhelmed. You've got breast cancer. You want to get done. Does that make sense? And a lot of women over the years, they tell me they didn't know what was going on. It's like a bus had hit them. They just wanted out. Does that make sense? They didn't ask questions. They just said, I want my breast removed. Yeah. So I would say that number is increasing right now. There's, I don't know if you heard of the Go Flat movement. So there's more people, and there's actually a good resource if anyone does want to go flat, called Not Putting on a Shirt. So basically that goes through all of that. I'm a little biased because I see people for breast reconstruction, but I do see people for aesthetic flat closure as well. But in general, most people I see do want reconstruction, like, because that's, you know, but I will say people are a bit more aware now, because before, if someone told their breast surgeon, I don't want reconstruction, I may not even see that patient, right? Because the breast surgeons, it saves time because they can just schedule the mastectomy and they don't have to wait to see one of us, right? Because that takes time as well. So when someone says, I don't want recon, they're like, okay, fine, we'll just put you on the schedule and do the surgery, right? But in general, there's still many women that want reconstruction.
You know, when I had mine done,
Yes.
they told me I was not a candidate for reconstruction.
Right. And again, there's a number of reasons
So
for that.
I
Yeah. Well, the other thing is a lot of people don't do Goldilocks, which I think is a good option for some women who, you know, may not be candidate for implant, may not be candidate for flat, but you already have all that skin. But you need to have a plastic surgeon that is on board to do that and offer it. Because it, you know, it was first described in 2012. That's when I did my first one as a chief resident back then, and we did the first one. And basically, not everyone knows how to do it. Does that make sense? Yeah. Okay, well, thank you everyone for coming. I hope you learned something. Oh, yeah, we answered that. Okay, bye everyone at home. You're welcome, Mary Beth. Good luck. Um, da, 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 da. Oh, spend my day.